Po tayo sa last segment for the day, na day 2 ng PGH IM Summit. We have a very interesting panel discussion on chronic back pain. Problema po ito ng maraming tao. Sa panel na ito, meron po tayong kasamang rheumatologist, orthopedic surgeon, marami pang ibang mga spesyalista. Panoorin po natin.
Pressure yan. Lahat sila nandito, wala namang pressure. Stand by 30 seconds. Quiet lang po na po. 30 seconds. Stand by.
Ay,
Kamusta ako sa
sorry, I'm blocking you.
Kamusta ako sa streaming? Stand by. Baba.
I hope that you all had a productive time learning a lot from the lectures in track 1 and track 2. We have one more presentation before we call it a day. So the next plenary session is a multi-specialty panel discussion on musculoskeletal pain, back pain, updates on diagnostics, and management. So our panelists are Dr. Geraldine Zamora Abrahan, Dr. Frances Ann Carlos, and Dr. Samuel Arsenio Guzman. And our moderator is Dr. Mark Evans Abad.
Allow me to begin by introducing Dr. Geraldine Zamora, who will be sharing her expertise from a rheumatologist perspective. She is a clinical associate professor of the Division of Rheumatology in UP-PGH, as well as an active consultant at St. Luke's Medical Center Global City and Manila Doctors Hospital. She's also a recipient of the Outstanding Young Men and Women for Medicine as Science and Art in 2016. Our next speaker is Dr. Frances Ann Carlos, who is a doctor in rehabilitation medicine at the UP-PGH, and she is the chair of the Department of Rehabilitation Medicine at Qualimed Hospital, San Jose del Monte, Bulacan.
Dr. Samuel Arsenio Guzman is an orthopedic spine surgeon and an associate professor of the Department of Orthopedics in UP-PGH, as well as the chair of the Department of Orthopedics at Asian Hospital and Medical Center. Moderating this multi-specialty panel discussion is Dr. Mark Evans Abad, a clinical associate professor of the Division of Adult Medicine in UP-PGH.
The following are the objectives for this plenary session as shown on your screens. Now let's all welcome our moderator and speakers.
Stand by. Pasa.
Nakita?
Hindi po, wala. And go live. And pasok. Zoom in.
Okay, thank you to our panelists for joining us this evening. Okay, and I'd like to thank the audience for staying with us this evening. Okay, we'd like to start off this panel discussion by showing you a simple case sampler as a jump off point for our discussion this evening. So please show the slide. Okay. So we'll start off with 3 case samplers as a jump off point. Okay. So we'll just like to discuss some cases. Okay. One would be a 30-year-old male with no comorbids who leads an active lifestyle and has no history of recent trauma. He complains of low back pain that happened the day after a gym session. Another would be a 55-year-old female with controlled hypertension and a fairly active lifestyle and does gardening and housework. She's already menopausal at 46 years old and overweight and complains suddenly of back pain after trying to lift a rather heavy plant pot. Okay. And lastly, we have a 75-year-old female who is diabetic, dyslipidemic, and hypertensive, but ambulatory with a cane. She already had a history of a fall and has a BMI of 20. She complained of back pain after the car she was riding in drove over a deep pothole. Okay, so panelists, these are just simple cases that we may encounter in our clinical practice, and I'm sure a lot of our audience practitioners have encountered similar cases. But of course, back pain is not limited to these cases, and I'm sure there are a lot of other variations and other cases out there. So, we'll go to the first question and first concern maybe of a lot of our practitioners out there. Do you really have to do an X-ray whenever you see a patient complaining of back pain? So we'll start off with Dr. Grossman, sir.
Yes, good evening. We don't need to do X-rays for everyone. It's only when we see the red flag signs that we order for X-rays. Additionally, when we do order X-rays, we try to limit the amount of radiation that passes through the body, especially the reproductive organs. So it would be better if we order for a PA rather than an APV if we're going to order an X-ray with a patient with red flag signs.
Okay, very interesting. Thank you for that. Okay, how about you, Dr. Fan?
So in general, we have to wait for around 4 to 6 weeks. So for non-specific low back pain, as mentioned by Dr. Grossman earlier, if there are no red flag signs in the patient, we can do trial of conservative management for around 4 to 6 weeks. So this would include medications, conservative treatments such as physical therapy, orthosis, and rehab before we can request for an X-ray. So we request a PLS APL most of the time if there is no there's no improvement after trial of conservative treatment, or if there is progression of the neurologic deficit.
Dr. we are talking about red flag signs. So what are these specific red flags that we are talking about?
Well, for the case that you showed, the first one is a 30-year-old male who had pain after his gym session. If this were presented differently, but if he's been having repeated back pain, especially the low back, over several weeks, even months, and if on history he says that it's worse when he wakes up in the morning or if it wakes him up at night, then that's already a red flag. No? If the pain eases with activity, if it improves when the patient is stretching or moving about, then that's another red flag. For the other cases that you've shown, red flag signs could be the ages, because they're more senior. The third case seems to be of low body mass index, not undernourished, but she's not on the heavy side, which is also a predisposition to having osteoporosis, low bone mass. And if there are neurologic signs, those could be also red flag signs.
Okay, that's good, that's good. Okay, any other points that you will add on, Dr. Francis, Dr. Sam?
Probably aside from the red flag signs, we should also check for what we call the yellow flag signs. So these are psychosocial factors which can contribute to chronic disabling low back pain. So for us to easily remember it, we can remember CT and E. in F. So C, catastrophic thinking, you can check that in the patient. Then compensation problems, usually work-related problems. For D, presence of depression. E, excessive time with rest, so extensive time off work. And for F is the presence of fear avoidance behavior. So the patient sometimes is hesitant to do activities as simple as walking because they're afraid that it can injure them.
I would be very much worried about the third case, primarily because of the trivial injury with regard to the history. Pothole lang ang kalaban natin, sumakit na ang likod ni Lola. So this is a red flag for me already, and I will pursue this.
Okay, very good points, very good points. Okay. We'll go on to another concern of ours, and we've seen a lot of patients ask us in the clinics whether or not another particular complaint in another part of the body, let's say the knee or the feet, whether or not it's related to back pain. Okay, can you tell us in your experience how this relationship happens or works?
Maybe I can start answering that because in rheumatology, what we're usually more concerned with is a patient. When a patient comes to us with back pain, of course we'd like to ask them if there are associated joint pains. For example, are there, like you said, knee pains, are there hand joint pains, toenail or toe pain, and other areas of pain because it's not just, usually in rheumatology when we see patients, they're usually systemic in nature in terms of the pathology. For example, if they have appendicitis, that would also cause pain such as heel pain, maybe shoulder pain, that can maybe help us in the diagnosis. This could be like spondyloarthropathy. And if they have pain on other sides, it could be like, for example, rheumatoid arthritis, if the pain is predominantly symmetric, polyarthritis. So there can always be correlation, not just with joint pain, but also changes in the review systems. So basically, thorough history is really important, as well as physical exam whenever we encounter patients.
Maybe that's a good point. And then the other system, this may be connected with the multi-systemic problem. How about problems in the knees or the other joints that may lead to a compensatory or another problem in the back as a result of poor compensation? Does that even happen?
So we should remember that in evaluating the patient, the body is a kinetic chain. So any change in the joints, the ankle, the hip, the knee can influence the lower back. So for example, in one study among arthritic patients with varus deformity, the varus tossed when the patient is on stand space on the affected leg actually increases the risk of low back pain by 3.6 for patients with varus deformity. Then for patients
or sa ankle.
yeah. For patients with ankle problems and foot problems, so the excessive pronation of the foot can also contribute to risk for low back pain. And lastly, for osteoarthritic changes as well, which can lead to limitations in extension, this can lead to a decrease in the lumbar lordosis. So we can have problems with flat back syndrome, wherein the patient is hunched. So all these joint problems can influence the low back pain.
Okay, that's a very good clarification point, ano?
Yes, I would like to further elucidate on the kinetic chain that Dr. opened up, Dr. Carlos opened up on. Like all of us, the body is well connected with one another. Just to give you an example, if you do have changes over your knee, it can actually cause your back pain at the end of the day. With the asymmetry of your normal gait patterns, you might end up overusing one side over the other, thereby causing pain. So these things should always be taken into consideration whenever you're planning for your treatment of your patients. We might end up falling to the trap that we're just looking at the back without looking at the patient as a whole.
Okay, that's very good point, ano? Kayo sa audience natin, have you noticed na this is a situation that is very common for a lot of people? So you should check yourselves kung merong ganung problem na kayo, any knee or hip problem that may cause your back pain. Okay? Sige, we will go to the next part of our panel discussion. Ano? What diagnostics would you usually order for particular situation, considering the patient profile in this situation? Anybody can answer at this point. So, Sam, you can go.
Let me begin. The first case, I probably, if there are really no red flag signs, I don't think I need to order for any imaging studies. Even with high sensitivity of your MRI, it doesn't lead to better outcomes. So for non-specific low back pain, even your advanced imaging won't really help that much because they do well, no matter what we do.
So, in what situations would you recommend an MRI for your patient?
If I do have a history, one of the things that I look out for would be a history of cancer. If you have a history of cancer, I would be hard-pressed not to investigate on this. I usually start with an X-ray, and I usually do a stepwise progression before I even order for an MRI. There are several things that you can get from an MRI that would probably be very, very important compared to that of an X-ray. If we're ruling out an osteoporotic fracture versus metastasis, you can find out there are some signs that you look for in the MRI that would help you in the long run.
Dr. Frances?
For the first case, probably you could also rule out disc herniation, no, since it can be a traumatic incident. So for that case, we can request for a plain MSMRI. Ideally, if the patient has medical suspicion by Dr. Grossman earlier, we usually request for MRI with contrast. So in this case, we can also request for MSMRI. And however, MRI is non-specific to which structure actually may cause the pain. So another thing we can request, especially if the patient is presenting with radicular symptoms, is an electrobiographic study or an EMG and CT. However, this is best requested after 4 weeks. Since during the first 4 weeks, we won't observe any denervation changes at that point. So it should be done later in the course of the history.
Okay. And how about you, Dr. Agin? Anything else?
Well, based on the cases that were shown, none really would require much workup additionally from rheumatologists. But if we were to change the scenario a bit, for example, the first or the second patient would have presented with chronic low back pain already that has the characteristic of inflammatory back pain, which is worse in the morning or wakes them up at night, and improves with activity or stretching, then maybe I would like to check the x-rays of the sacroiliac joints, like maybe order a sacrum PA or a pelvis ATU just to check the sacroiliac joints. Or if it's chronic and the index of suspicion is high and the x-ray is negative, then maybe we can proceed with an MRI of the sacroiliac joints, or it's just it can just be a plain MRI. Just request for a coronal oblique view of the sacroiliac spine, and maybe we can see bone marrow edema, which speaks of inflammation that may be seen in patients with ankylosing spondylitis or spondyloarthritis in general. And maybe at this point, I'd like to emphasize that we should try to forget this scenario that we have learned in med school that young males can have AS and females cannot, because actually females can have ankylosing spondylitis, and there is an entity called non-radiographic eggshell spondyloarthritis. I'll repeat, non-radiographic eggshell spondyloarthritis, or NR eggshell SPA, wherein there is spondyloarthritis, which is an inflammatory type of arthritis. It's different from spondylosis, which we see on x-rays, which speaks of osteoarthritis of the facet joints. So people with non-radiographic eggshell SPA will have normal x-rays, but may have MRI changes that speaks of inflammatory arthritis. So it's something that is evolving in terms of diagnosis and management.
Okay, so thank you for differentiating the spondylosis and the spondyloarthropathy. How about any other exams like blood exams, blood tests, or other specialized tests for connective tissue disease, for example, or other conditions?
So if we are suspecting that the patient may have an inflammatory type of back pain, we can request for an inflammatory marker, could be the CRP or just an ESR. And this can be high in certain instances, but not always, because it doesn't always correlate in terms of people can have inflammatory back pain and have normal acute phase reactance, but that's a start. And if the suspicion is high, and especially if the patient can afford, then we usually request for an HLA-B27 test. It's a gene test. If there's enough suspicion that the patient has had chronic back pain, worse in the morning, improves in activity, and we're able to rule out other more common causes. So that would be one of those. If this were female, maybe predominantly in females, there could also be other types of arthritis, such as connective diseases, like we just said, with RA or lupus, and we can order antibodies for that, autoantibodies. So it depends on the clinical situation and scenario.
Okay, before we go to the next set of questions, I'd just like to ask Dr. Sam again, if you're considering maybe 2 more or even next, do you have any particular diagnostics that you order for these conditions to when you are checking for back pain, if you are considering tumors, for example?
Yes, when you're dealing with the elderly, we know that most of the tumors from the spine will be metastatic in origin. As such, after getting the x-rays, if we see signs that are compatible with metastatic disease, like multiple skipped areas, loss of your owl-wing sign, what you see with the absence of the pedicle, you see more posterior involvement, and a more lobulated posterior cortex on the MRI, you probably start thinking more of a metastatic process. Sad, but the way we do it is that we end up reviewing patients, looking for a primary. We try and search for our possible primary, but if this is very difficult, then you have nothing to show for this, you'll have to go through the statistics. You play the numbers game. You try to rule things out. And you also try to look for an accessible area for biopsies. You look for lymph nodes, etc., etc. Because the key is finding out what the primary is before you can start or institute any treatment. All right.
Okay, thank you for that, and that's very exciting. Okay, we'll go with treatment at this point. Okay, I'm sure a lot of us give very common medications for treatment of back pain. So, shortly, can you just discuss how do you approach treatment of back pain in a lot of your patients? Yeah, Frances, you can go ahead.
So for non-specific low back pain, the recommendation for acute non-specific low back pain is the first line is paracetamol, so an analgesic. Then the second line option is NSAIDs in this case. So we don't usually start immediately with antidepressants or other medications. Then we can also provide anti-spasticity, muscle relaxants. So this can include benzodiazepines and benzodiazepines medication. So in the recommendation of PALM or society, we prefer the non-benzodiazepines for non-specific low back pain. So this can include options such as antispasmodics, which are your Rexall, and anti-cholinergic, antihistaminic, which are phenytoin, and antispasticity medications such as baclofen, tizanidine, and dimethyl.
Okay. Toraging, for your patients who are mostly either with connective disease or some form of inflammatory concerns, how do you approach pain control in this situation or symptom control in this situation?
Of course, first we have to differentiate if the patient has a spondyloarthritis or spondyloarthropathy, which is different from the autoimmune systemic arthritis such as lupus and RA. So in the spondyloarthritis group, these are the ankylosing spondylitis patients, psoriatic arthritis, rheumatoid arthritis. So usually for this group of patients, we can start with NSAIDs because it exerts anti-inflammatory effect. You can give them chronic low-dose NSAIDs, of course, being mindful of the creatinine and cardiovascular status. But there will come a point, or there usually comes a point wherein we have to think of higher level medications or DMARDs in the form of biologic medicines or even the synthetic disease-modifying anti-rheumatic drugs, because we want to target not just the pain, but also the disease activity. We want to make sure that the patient does not progress to developing permanent damage in the joints and the emphasis, which can cause permanent debility. So we have different agents for that. For peripheral spondyloarthritis, we can prescribe the patients with methotrexate, for example, or sulfasalazine, or even flutamide, but it's not really widely available in the Philippines. Only the first one I mentioned is available widely in the country. But sometimes we have to ask them, or at least advise them, hopefully they can afford it, to start on a biologic medicine, which may include an anti-tumor necrosis factor. Examples would be the MAPs, infliximab, adalimumab, MAPs, or the IL-17 or IL-23 inhibitors. And these have been showing really good efficacy and have been providing much relief to our patients and halting disease progression.
Okay, okay. So very complicated armamentarium of medications. Okay. Before we go to the next set of our questions, again, I'll go back to Dr. Sam here. For your patients with bone metastasis, for example, presenting with back pain, what options can you give these sets of patients aside from the usual treatment?
Well, the primary management is to actually control the lytic process that you have with these patients. So one of the strategies that you can be using would be your zoledronic acid to decrease the metabolism of the lysis or to decrease the rate of lysis of your bones. We usually when they're referred to us for metastasis, it's a little bit late in the game and you have patients with a lot of complications. You see the hypercalcemia already, you see some kidney problems as well. So thank goodness we do have some other medications in the form of denosumab, which can actually help them cope as well. This apart from the pain medication strategies that we are utilizing. Can I go back to that question with regard to the pain a little bit more? I'd like to elucidate further that when we do take care of the patients with low back pain, we try to, it cannot be just a stepwise progression of medication. You have to think in your mind what the cause is. Is it inflammatory in nature? Are we dealing with something that is neuropathic? Or do we have nociplastic changes already in our patient? These will have to be taken into consideration when we're starting to treat them. When they're relatively acute and we do have muscle spasms, then focus on the muscle spasm. If we think that it is an acute disc herniation, then maybe you have to start with an anti-inflammatory medication, which might be self-defeating, right? As we discussed earlier. But I think focusing on the pain-generating structures would actually help you to become successful with the management of your patients.
Okay, so for everybody, how's your experience about vitamin D, other vitamins, other supplements, and other available over-the-counter remedies out there? Anybody?
So maybe I can answer this first. If it were just mainly for back pain, I think we have to make sure first if the patient is lacking in vitamin D maybe or calcium, and then maybe those are the points for supplementation. But if we talk about other supplements in rheumatology or maybe even in rehab and ortho, such as glucosamine and also collagen, I think these warrant more investigation in terms of which patient we will give these to. For example, glucosamine sulfate may be indicated for patients with osteoarthritis of the knee, but that's it, no? The indication for other types of arthritis may not be seen for that particular supplement. So I think it depends on the patient profile.
Okay. So we need to go further now, okay? We are on the last part of our panel discussion. Dr. Francis, on the rehab side, what can you generally offer for our patients with back pain?
So for patients with acute back pain, one of our options are prescribing orthosis. So our main goal is to first provide an anesthetic reminder. So second is also to limit the motion of the patient. And if in cases if it is unstable, we should provide a more rigid brace for this patient. So it's just for pain control and stability issue, that's fine. However, this should be removed gradually later on since we want the patient's core to work as the brace itself. So exercise is very important for patients.
Dr. Sam, any recent, latest surgical maneuvers that can be done for certain causes of back pain?
The number one operated condition of the spine is lumbar disc herniation. We at the Department of Orthopedics at the Philippine General Hospital actually initiated the first endoscopic lumbar spine surgery in the country way back in 2012, 9 years ago. So originally, when we used to do the laminotomy to be about 2 inches, we managed to decrease it down with the tubes by about 2 centimeters, and now we can manage to do the discectomy with an incision that is about 0.8 of a millimeter. The outcomes are very good, and it's very similar in the forecast literature with an open discectomy. However, it's still more expensive than the regular surgery. However, if you operate on a patient this morning, this afternoon this patient is walking already.
Okay, lastly, any other experience with other modalities like TCM, traditional Chinese medicine, dry needling, acupuncture, anything of the similar nature?
For such in general, injection and dry needling, they have a good response for patients with low back pain. However, this is usually used in collaboration with other modalities. But the most important part is the exercise for patients with low back.
Okay, so I think we've covered a lot of important topics here in this discussion. And again, I'd like to thank my panelists here for a very splendid discussion. We covered a lot of things, okay? And I do hope the audience was able to get a lot from the discussion that we had here this evening, okay?